Thanks, Vero. So Dr. Lene Seidler, as he said, is a professor at the German Center for Child and Adolescent Health in Rostock, where they hold the chair for health equity. She's previously worked as the research group lead at the NHMRC Clinical Trials Center at the University of Sydney. Lene has led and continues to lead several large international collaborations. Most relevant to this talk was the ICOMP collaboration, which used data from over 60 studies, including more than 9,000 babies, to evaluate the comparative effects of cord management strategies such as milking, delayed cord clamping on neonatal mortality and morbidity. So very relevant to our talk today. The results of that collaboration has been published in multiple high impact publications and heavily informed the most recent ILCOR guidelines on cord management at preterm birth. So welcome, and we're very lucky to have you here to lend your expertise on this topic.
Thanks for having me. Hi.
All right, and I have the honor today to introduce Dr. Anup Katheria, who's the director of the Neonatal Research Institute at Sharp Mary Birch Hospital for Women and Newborns. He's also an adjunct associate professor of pediatrics at UC San Diego, where he teaches POCUS and echocardiography for their trainees. He's a content expert for the International Liaison Committee on Resuscitation, and most of his work has been focused on delivery room interventions, including several multi-center, multinational trials in umbilical cord management, included cord milking and intact cord resuscitation in term and preterm infants, and less invasive surfactant administration. He's a center PI for the Sharp Hospitals, which is the first standalone community hospital to ever join the Neonatal Research Network. And he is lead author on the MINVI Trial, which we will discuss today. Welcome, Dr. Katheria.
Thanks, Maddie, appreciate it.
All right, and now we can turn it over to our trainee presenter, Colin Parker, to share his slides and his lead our discussion today.
Okay, you guys should be seeing my slides. So good afternoon. In California myself, so Pacific time. Welcome for everybody who's wherever you're logging in from. So I'm gonna kick off the discussion about this study that came out, I believe earlier this year, on the 2-year outcomes of umbilical cord milking for non-vigorous infants, the secondary analysis of the MINVI randomized controlled trial, which I'll spend a good amount of time talking about. Leading up to the presentation, met with Dr. Katheria a couple of weeks ago to provide some context, and really appreciate all the mentors that are here and helped me as I worked through these slides in preparation for those. So no pertinent disclosures. As far as objectives for today, I whittled them down to 3 main things. The first, we're going to talk about umbilical cord milking broadly and where it has been applied or tried. There's a long history of umbilical cord milking in our field, but I think this the kind of rigorous study and using RCTs to really define when it's helpful is relatively new and something that our field's just learning about. One of those is the milking in non-vigorous infants trial, shortened to MINVI, which is the main focus of our discussion today. And then the paper that I was asked to focus on is this one, which came from the MINVI trial, the 2-year outcomes of umbilical cord milking in non-vigorous infants. So Dr. Katheria is the lead author on this, and then many of the other studies that I'm actually going to bring up that informed the context of getting to this study, getting to this design, and why we think this is an important study to review. So some background, I'm going to touch on a lot of things, but really focus on defining some definitions for the purposes of our main study that we're discussing today. So we all practicing neonatology know that delayed cord clamping is now the standard of care for vigorous term infants. So across my 3 training institutions, and I'm sure broadly across just about where everyone works now, it's widely accepted that delaying cord clamping for at least 30 seconds, sometimes 60, maybe a bit more, is all desirable for vigorous infants. But the population we're going to talk about today is understudied, and that's the non-vigorous infant. There are concerns about delaying cord clamping because it could delay resuscitation. And we'll talk about one study that was ended early because of the concern about IVH in preterm infants with cord milking. And then the concern for hypothermia, especially for babies in the OR and cold ORs, delayed cord clamping can, it can be wet at the perineum before coming over to the warmer. So the recommended management prior to this work had been to clamp the umbilical cord immediately after birth, or what's termed early cord clamping. So I'm going to use that shorthand occasionally. But umbilical cord milking provides an alternative to delayed cord clamping for non-vigorous infants. So the potential benefits include improving the cardiopulmonary transition, support cardiac preload, reduce morbidity. Umbilical cord clamping can be performed more quickly. It may provide similar benefits to delayed cord clamping. And I just want to note here that the delayed cord clamping with resuscitation is another alternative to umbilical cord milking that has been studied, but it's not the focus of our discussion today. So I just want to mention that as something that has been looked at as a potential, but it's outside the scope of the study that we're looking at today, but it is worth mentioning. And just while we're here, a couple definitions. So our study, the MINVI trial defined non-vigorous infant as any of the following present in the first 15 seconds after birth and prior to cord clamping, as determined by the obstetric provider. So those include poor tone, pallor, lack of breathing despite initial resuscitation efforts like stimulation, potentially plus or minus oral suctioning, and per the local resuscitation program guideline. As far as umbilical cord milking, so that is defined as 20 centimeters of cord milked towards the baby over 2 seconds and repeated an additional 3 times. So a total of 4 milking with intact cord. That's how the study defined it and how it was carried out in the MINVI trial. Just want to mention one more time, the cord milking has a long history. Has certainly been done in various clinical contexts, but I'm not as familiar with the evidence base for that over the past 30, 40 years, but I do know that this is one of the more recent important studies to look at the topic. So this slide I pulled from Dr. Jenny Kuh's nice 2013 Frontiers in Pediatric article about umbilical cord milking. This diagram outlines some of the potential therapeutic benefits for both preterm and term infants of umbilical cord milking. We don't really, this diagram is more broadly applicable than the population we're discussing, which is the near term and term infants. The risk of ROP, of course, is pretty low. Risk of BPDs, not really relevant for this population, but I just thought it was a nice diagram to include. And I forgot to mention at the start that the studies I'm going to mention all have QR codes, so if you're interested in pulling them during the presentation, you can just do that. But the references are also provided at the bottom of the slide. I think another relevant study that led to the MINVI trial was this, I'm forgetting the name of it, PredMod 2. This was published in 2019. It was an RCT that had to be stopped early due to concern of among the preterm population that was studied, there was a higher risk of IVH. I think some of the same centers were participating in this study that ended up in our MINVI trial. I have a couple key points from this. I'm just going to touch on this lightly to provide context for the concerns for umbilical cord milking, especially in our preterm population. But again, different population than the one that was studied here. But the RCT was stopped early, about a third of the way through recruitment, due to the umbilical cord milking group having significantly associated higher risk of severe IVH, so 8% versus 3%. Shifting our focus to the study that led to the secondary analysis that we'll discuss most. That was the umbilical cord milking in non-vigorous infant study. It was a cluster randomized crossover trial. I'll speak to that in methods in a minute. The hypothesis is that with umbilical cord milking, we could reduce NICU admissions compared to early cord clamping in non-vigorous newborns born near and term. So briefly, the PICO breakdown would be non-vigorous infants born at 35 to 42 weeks. The intervention would be umbilical cord milking. The comparison group would be early cord clamping. And that primary outcome was the rate of NICU admissions. And they had a series of secondary outcomes, which I will get into in the results.
Colin, before you go on, I wanted to, if you go back to the prior slide, ask Dr. Katheria, you mentioned the Premod study, which I think definitely sits in a lot of people's minds when they think about cord milking in the NICU, but obviously it's a different population and potentially different needs. These are non-vigorous infants versus infants that may not need additional resuscitation. But just thinking about when you planned the original MINVI trial, how that influenced decisions around the study design and enrollment and how you were going to set this up.
Yeah, no, that's a great question, Brian, because we had just stopped the trial and were evaluating. MINVI had already been funded. Part of the struggle we had was really being comfortable that older babies would not develop IVH, older preterm, or I should say the right word is more mature preterm babies above 28 weeks. Were we comfortable enough that they weren't developing IVH? And then if you extrapolated that to a 35-weeker who's older, who's also at risk of brain injury just by being non-vigorous, would those kids be at risk? So looking at the data we had in those older babies at the time, we felt very comfortable because there was virtually no severe IVH or IVH that we were seeing that was even trending in the wrong direction with cord milking. There was something about that physiological breakpoint, and I don't know if we'll get into this at the talk, but for babies that are 27 and lower, there's just much more fragility there, and the ability to handle that volume that we thought would not be as a concern for babies who were more developmentally mature. So we felt okay, although I will tell you the ethics of doing, and I know Nasa put this talk about getting a waiver of consent. You have to be pretty convinced from a risk standpoint, talking to IRBs, and we had to go to 10 individual IRBs to sort of make this work. And so that was definitely a challenge at the time without knowing good data about any harm with milking in that population. So not an easy thing, but something we sort of delicately said, well, either way, we need to sort of answer this question of milking babies in the older population to see if that was a risk or not. So I don't know if I answered that fully, but.
Yeah, thank you.
Mm-hmm.
Great, thanks for that. So the MINVI trial was designed as a cluster randomized crossover trial across 10 sites. 7 were in the US, 2 in Canada, and 1 participating site from Poland. There were 2 periods, and during period 1, each obstetric provider at each institution would train in identifying non-vigorous infants and performing the assigned intervention, either early cord clamping or umbilical cord milking. Centers were randomized to one or the other to start. Once the goal enrollment was reached for the whole study, so my understanding is like 600 recruited patients across the 10 sites, then that stopped period 1. And then the whole, this is my understanding, please correct me if I'm wrong here, but then that began like a 1 to 2 month washout period where all of the centers would then train in the other intervention.
Yep,
So if you were, is that right, Dr. Katheria?
that's right. Yep.
So if you were an early cord clamping group period 1, once 600 infants were recruited, then everyone, all the sites say, okay, we're done recruiting now. Everybody spend a month or 2, retrain. Everyone's going to switch. There was this note, which we can talk about, or it might be not as important, but 9 of the 10 sites approved a waiver of informed consent for minimal data collection, which I think is interesting. We can talk about this more later on, but my understanding of the recruitment, because of the nature of the intervention, you don't know which babies are going to come out non-vigorous. And so the study group took to the different hospitals this plan for the research study, but and 9 of the 10 sites said, okay, you can gather certain basic data on how babies that were non-vigorous did. Did they end up in the NICU? Some demographic data, some really some basic stuff. But there was one site that had reservations about providing that without informed consent. And so I think we can just leave it there for now and come back to that later. The focus of the secondary analysis that we're talking about today actually involved just a portion of those initial infants that were in the primary study. And we'll go into why that wasn't everybody, but it's because there was informed consent for the secondary analysis to be performed, the neurodevelopmental outcomes to be assessed. I have the exclusion criteria here in my notes. I'm just going to move forward because it'll take a long time, but to go through. So I just wanted to spend a moment to, at least for me, when I first looked at the study, I did get caught up on what this pragmatic cluster randomized crossover design meant. So a cluster study is, it's a way to randomize clusters, in this case, a hospital, so that the whole hospital or the whole practicing group would do the same intervention for a while. So instead of individualizing random patients, so because that would be very hard to do, the assessment or an included baby would be determined only after 15 seconds of life. And then if you try to randomize at that point, that can be chaos. So instead, that's how the study design arrived at, you're either going to do intervention A or intervention B, and the whole hospital is going to practice that for that period. So this cluster design helps prevent contamination within groups. And then the crossover piece is that each cluster receives both interventions at different times. So that's what hospitals would train for intervention A, which is early cord clamping, have a washout period, and then they would move to intervention B, which would be the cord milking. So my understanding is this approach allows each cluster to act as its own control, and that actually enhances statistical power with fewer clusters. And then
Dr. Seidler, question for you, since considered an expert in this. So it's a pretty unique and ingenious way of designing the study design and stuff. Could you comment for our trainees in the audience about this study design structure and what all scenarios this study design is useful and the pros and cons of it?
So was that for me or for Colin? Sorry.
For Dr. Seidler.
Ah.
Yeah.
Go ahead, Lene.
Yeah, I'll first start with her and we'll come back to you, Dr. Katheria.
Yeah, I'm sure Anup has lots to say about it because he's the one that employed the design. But I mean, it's a useful design in that it's often a lot easier to train a center to do one intervention consistently rather than having to randomize each infant. And that's particularly true when we don't know how infants will arrive. So I suppose, and Anup, correct me if I'm wrong, but the other consideration would have been to randomize every birth, and then the ones that are non-vigorous are the ones that are included, which would have meant having to consent and randomize a very, very large number of infants. So randomizing centers means that then every infant that's born non-vigorously can get the assigned intervention without having to kind of do that randomization at birth. So that's a major advantage, and that's why it makes a lot of sense to apply this kind of method in this case. There are some risks of bias, just because you may have center effects that come in. So that's why it's good that there was an modeling approach used to kind of try to account for that. The more centers there are in a multi-center study, the less there is that risk of bias, because they kind of balance each other out. And also the fact that, sorry to see your question, Brian, I'll answer that next. So yeah, and the fact that it was then crossed over, I'd be interested to hear from Anup what kind of, how compliance maybe changed when a center did one thing and then the other. But I think that's another approach of trying to control for some of these center effects that may otherwise be introduced. ICOMP didn't include cluster randomized trials, and that's just because there weren't that many, because ICOMP didn't look at this specific group of non-vigorous infants. It was a lot easier to tell when a baby was going to be born preterm and then randomize it then. So for that kind of research question of looking at preterm infants, it made more sense to only include trials randomizing at the individual level, and we only had to exclude 1 or 2 trials because they were cluster randomized. So if there had been more, would have possibly chosen another approach, but because most relevant trials for ICOM randomized at the individual level, we didn't have to deal with these extra complexities.
Dr. Katheria, can you enlighten us about why was this design chosen over traditional randomized trial? As Dr. Seidler already pointed out, some unique challenges. I think it's a design we've rarely see in neonatology, but a pretty important intervention, especially during delivery where we don't know about the status of the infant.
Yeah, no, and I think, Lene brings up a lot of good points as far as analysis and interpretation of these studies. The real reason was it's just impossible to identify a baby who's non-vigorous. And no matter what you do prenatally to look at delivery factors, so often it's a baby who's the pregnancy and the delivery, induction of delivery of the labor is going well, and then the baby just comes out looking poorly. And yeah, as Lene mentioned, it would be impossible to consent and enroll a bunch of every baby at every hospital and then just take the non-vigorous ones. It's beyond like even pragmatic or possible. And the idea of individually randomizing a patient who's limp, not breathing, et cetera, you can only imagine the risks of that. So we thought from both a practical as well as honestly an ethical standpoint that parents would be more likely to be comfortable knowing that their child was in a study where the entire system was doing one thing for those babies for that period of time and then another. It's not exactly like QI, but it sort of feels like QI, I think, when you're comparing it to RCTs. But the limitations are many. We've been docked in meta-analyses and other things because of this risk of bias. And Lene pointed out too, because the providers know what is going to happen to the baby. I mean, my argument as a neonatologist is that, I don't really care if I'm going to know if I'm going to milk or clamp early. The baby's going to be what the baby's going to be at the end of the day. It's harder to sort of put that into effect. But it is there, and I think that's what makes it harder to do meta-analyses for. I will say, though, it's becoming, I know at least 3 other trials that are using this exact design of cluster crossover. It works really well with delivery room resuscitation studies, I will say. And so I think you'll see more of these. So for trainees or people looking to do studies, particularly when you don't think you'll be able to obtain antenatal consent, I really think it's a good approach. You just have to understand, compared to individual RCTs, and this is, I think, getting to Lena's point, it's statistically inferior. You really have to do adjustments by center. You have to count for center effects much more. So it becomes harder. And for what Lena is doing with individual patient meta-analyses, I think that's where it becomes a bigger challenge, because that's really what we want to get down to, is how do you combine all of these studies and sort of being able to look at the effect of them combined. So I think she's going to have her work cut out for her as more studies come through in this space, because she's really the world's expert when it comes to IPD data. So I think
I can, yeah, thanks, Anup. I can actually, so the good news is we can work with these data sets in IPD meta-analyses as well, and we have done so for kind of different research questions. And I think if we were to do one on these non-vigorous infants, which is something we should consider doing anyhow, we would certainly want to include these kind of study designs, because they make so much sense here, because it's so hard to do these studies otherwise. Yeah, so just to add that.
Yeah, some really good points for a future trialist here. Colin, you want to move ahead?
Sure. So I have a few slides on the results of the MINVI trial. Among non-vigorous infants born near term or term, umbilical cord milking did not reduce the NICU admissions for predefined criteria. So the primary outcome was not statistically different, but there were some secondary outcomes that were different. So babies in the umbilical cord milking arm had received less delivery room cardiorespiratory support. I'll show how that was defined. Lower incidence of moderate to severe HIE, and there was less therapeutic hypothermia among the umbilical cord milking group. So these are some of the tables from that study. As you can see here, the NICU admission, which is the primary outcome, was not significantly different once the study design was accounted for. Here are the predefined reasons for admission that were considered included for the MINVI trial. There are other reasons babies get admitted to the NICU, like antibiotics for EOS, and those were not considered those were not included here. As you can see, the composite score of any cardiorespiratory support, there was a statistically significant difference. So among the umbilical cord milking group, 60% received, whereas the early cord clamping, 70% received. Similarly, for therapeutic hypothermia, 21 of these babies in the umbilical cord milking group, which was about 2.5%, underwent therapeutic hypothermia, whereas in the early cord clamping group, 35 babies did, which is 4.3%, and so that was significant. It's worth pointing out, roughly half of the infants with HIE in the milking group presumably had mild HIE because they were cooled, versus about a third of the early cord clamping group were cooled. So just kind of some interesting things when you kind of parse through the data about why that is. As you can see here, so the as defined in the two different groups, so moderate to severe HIE was diagnosed in 1.4% of the umbilical cord group and 3% in the early cord clamping group. But that goes to what I was saying, that there was a higher percentage of babies that were cooled in both groups than just met moderate to severe, and I think that goes towards kind of a discrepancies among centers about who cools milds and how we cool milds, and so beyond the scope of what we're discussing. So this is a nice graphic that kind of summarized the results of the MINVI trial, and we could talk about this for the full hour, the MINVI trial, but I do want to get into the secondary analysis portion, which is what I was tasked with primarily. And so we can return to talk more about the MINVI outcomes as they're relevant. This was a pre-planned secondary analysis of the group that was recruited into MINVI. Of those patients that were randomized, after it was determined they were non-vigorous and were put into one of these cohorts, then the researchers would go and ask families would consent them to participate in the next leg of the study, which is what this is. So the goal was to follow up these babies with the ASQ ages and stages questionnaires at 6, 12, and 2 years. and then also perform an MCHAT at 22 and 26 months, I think, were the two times. The variables were assessed with these statistical methods: the Wilcoxon-Rank sum test for continuous variables, a chi-squared test for categorical variables. Intention to treat was performed, and all analyses were pre-specified in the trial protocol. This is beyond my scope of knowledge, but I have it here because I was hoping Dr. Seidler could help me out. But there's a hierarchical generalized linear mixed model that was used, which included fixed treatment group effect, fixed period effect, random cluster effect, and random cluster biperiod effect. I'm hoping somebody can help me understand what that is still.
Dr. Seidler, can you explain for trainees what's the differences between a fixed effect and a random effect is in study design and statistical analysis?
Yes, look, I can attempt to do that. So what we're talking about here, we can either have an effect that's kind of overall for everything, and then we can put random effects in the model that can account for different clusters having slightly different effect estimates. So we assume that there are kind of characteristics of each cluster that change how the babies will do. And putting those into the model alongside your fixed treatment effect just helps to take out some of that bias that we may otherwise introduce by having the babies being treated in the different centers. So it's a way of accounting for the babies being in the different centers and having this cluster randomization that, yeah, is the right way of doing this here. Is that helpful?
Yep. Thank you so much.
So here are here's the table 1 for the secondary analysis. There's no significant differences between the groups, the umbilical cord clamping and the umbilical cord milking and the early cord clamping groups. I just brought this up because it is something that later will be discussed, but it was a fairly highly educated group of participants. So, at least 78% from each group had attended some college among the moms that consented to participate. And I think as we think about the more generalizability of the results, that's one of the things that probably not representative of many of the patient groups that we care for. So as you recall, in the initial MINVI trial, there were 1,730 patients enrolled. And then of those, 1,206 were consented for follow-up. There were 239 that no ASQ3 was included. And so the reasons for why those were not achieved are listed here. So it's nice to have that breakdown. The most common reason being no response from parents. So after delivery in the hospital, consented to participate, but then when they were asked to follow up with the parental responses later on, just no response there. So ultimately 971 patients were analyzed, and 964 ASQ3s were included. And as you can see the breakdown there, 502 were in the umbilical cord milking group and 469 in the early cord clamping group. So these are the results of those studies. So the umbilical cord milking ASQ3 scores are on the left, early cord clamping on the right, and the statistical tests in the far right column. So there was no difference in any of the developmental screening characteristics. Here are the ASQ3s. What's the difference between this one and this one again? This was this is the odds ratio on the likelihood of whether it was abnormal or not. And so again, odds ratios all crossed 1. So the whether you were in the umbilical cord milking or the early cord milking group, your odds were not statistically different that you would have an abnormal ages or stages questionnaire. And then this final piece is the MCHAT scores. So there was no difference between the two groups for, a higher score is indicative of, or any score greater than 2 is indicative of a potential developmental abnormality. And you can see the odds ratio is pretty close to 1 with a wide range there.
Dr. Katheria, could you talk a little bit about the choice of these sort of essentially screening tools, right, for neurodevelopmental assessments for this follow-up study, as opposed to, I think, oftentimes when we think about 2-year follow-up, particularly in the preterm population, especially, we're thinking about, neurodevelopmental assessments provided by experienced, neurodevelopmental pediatricians or neonatologists, whereas these are, forms for, in case anyone doesn't know in the audience, these are all forms that families are filling out to screen for disorders. So kind of talk about how that was discussed when you were designing the trial.
Yeah, I know. Yeah, Brian, you would make a great grant reviewer, by the way. So you're really attuned into the limitations of all of these things. So I appreciate that about you. So yeah, I think, originally we were hoping for in-person 2-year Bailey scores, the neurodevelopmental examinations. And we sort of thought about it, well, okay, how many non-vigorous babies, whatever you do to the court, and end up getting admitted to the NICU, right? So we're thinking about a quarter, and that's kind of what we ended up with when you look at the original trial. And then that leaves you with a denominator. Well, 75% of these babies just stay with the mother. And now you want them to come to a clinic at 2 years and do a 2-hour Bailey neurological exam. Yeah, that sounds great. And what do you think your follow-up rate is going to be? And so that's where I was thinking, well, do we take the hit on, yeah, these tests are not as sensitive of predicting milder, more subtler delays, which is the limitation. If you look at the literature on Baileys and MCHATs, on ASQs and MCHATs, you might miss more subtle things. But you can get closer to what scientifically is a more valid follow-up rate, which is we were aiming for 80% or higher, which is sort of the standard. If you don't, you have sort of biases as to which patients are being included or not. And I think, as Colin was alluded to, some of the younger families less educated may not have showed up to get these completed. But you want to get as much data as you can at the expense of the sensitivity of the test. And so, yeah, the data with ASQ for doing something non-in-person, ASQ and MCHAT have probably the best sort of predictive value of picking up moderate to severe impairments. The MCHAT is actually really good at picking up behavioral problems later. It's obviously an autism screener, but it's actually really good at looking at social emotional dependence later on as well. But yeah, you're right. You could miss some things that are more subtle with this. And our aim was really, could we establish enough safety with this? Because people were clearly so nervous about cord milking. And obviously, as Colin said, with our preterm data showing that IVH risk, how do you reassure people that this is safe? I think getting more patients probably is better, but if I could have gotten Baileys on these kids, absolutely, I agree with you. That would have given even more assurance that, hey, we're not missing anything subtle in these kids that would have been missed by an ASQ, et cetera. Hope that answered it.
That's great. So that leads us nicely into the discussion points. In conclusion, the umbilical cord milking did not improve or worsen ASQ3 scores compared to early cord clamping, but the short-term secondary outcomes in the original MINVI trial were favorable towards umbilical cord milking. So this study concurs with previous reports of placental transfusion trials that it's been tough to show any neurodevelopmental long-term benefit, despite the short-term benefits that we've seen with cardiorespiratory support. So I think the most recent American Heart Association, AAP, neonatal resuscitation guidelines state this pretty non-committal for non-vigorous term and late preterm newborn infants. Intact cord milking may be reasonably compared with early cord clamping. And so, as we've kind of showed with the MINVI trial and through the secondary analysis, that it's not harmful. And if anything, it might show some short-term benefits. So the limitations of the study, we've already addressed or discussed some of these, but the lack of more comprehensive in-person developmental assessment. So for all the reasons Dr. Katheria just outlined, getting a reasonable follow-up rate for these families who went home with basically healthy-looking term babies at 2 years with these long developmental assessments was determined to be unlikely. And so for the purposes of capturing more patients doing parental screenings that they could fill out with the MCHAT and the ASQ was sought instead.
Dr. Seidler, a question for you. Dr. Katheria brought out a really good point about, having a better test, but being pragmatic and doing something which is achievable, like ASQ and stuff. In your experience, are there any better tools than this, or ASQ is probably the best stuff for this, or is there something new in development which the trainees can use in the future?
No, look, as far as I'm aware, Bailey's is kind of the gold standard, and ASQ is what's being used when Bailey's isn't available. Some studies have done the Bailey's where possible, and then the ASQ where they weren't able to get that follow-up. But it's actually really hard to combine the data from the two tests. It's in general, I suppose, one thing that's quite annoying from my perspective is it's really hard to combine the different tests with each other, even the different Bailey's versions. So we're currently dealing with that because we're trying to combine all the preterm data, long-term follow-up outcomes. So I suppose in general, when trainees are thinking about which tests to use, looking at what similar studies have done and how that may be harmonized in future evidence synthesis would make our life much easier.
Dr. Katheria, do you have any comment on the developmental testing? I know Bailey has its own issues and the 2-year outcomes not falling with the 5-year outcomes and stuff for it. So where do we stand in terms of neurodevelopmental outcome follow-ups for our future trainees? What will be a good assessment tools for such studies?
Yeah, a really emerging area right now going on is the use of sort of telehealth. So there are a few studies that we're a part of in the Neonatal Research Network are discussing, which looking at things like where you can do a hind examination where the parent's holding the child and actually doing movements on the infant to then tell you whether or not the baby has CP. You don't actually have to be holding the child to be able to, as the provider, you can have the parent do these things and be able to score them. And then there obviously are better, as children get older, better assessments. You can use surveys and questionnaires for parents to fill out as well that are being looked at. So yeah, I think there is more potential for using telehealth. I mean, the one thing I will say, which I forgot, MINVI happened during COVID. And so to be able to do these questionnaires was great for us because follow-up clinics literally shut down across the US and globally. So kids weren't even able to get in. So to me, it was a lifesaver. Right now, as you know, if you're involved in any trials that are still following these kids, they've extended up the Bailey window out to 5 years to be able to get more of these kids and some data in them. And I think this is the struggle we're going to see with having to make sure parents do in-person exams. So I think, Viral, you bring up a good point to continue, and for other trainees that looking at these other almost like telehealth virtual assessments that might have some reliability and validity if you can get the parents to sort of help do some of those things sort of in conjunction. So it hasn't been like a primary outcome in any trial that I know of yet, but I think if people are looking at it to sort of develop it further.
Thank you. Colin, you can wrap up your discussion and then we can go towards further talking about the topic.
Sure. I do want to get a bit into the granular data. These are the limitations that were discussed in the study paper. I mentioned that moving from the MINVI trial to the secondary analysis, there was a consent process, and then patients were kind of recruited at that point. But it seems like the moms that were willing, or the families that were able to be followed up did skew a little bit older, a little bit more educated, and perhaps because they're in the hospital longer, more often were C-sections. So I just wanted to, this was a nice study, a supplemental table that was included, which I thought was really a good addition to understand why those groups differed. And then I had three main questions, I think, at the end of the day. Is this enough data to support umbilical cord milking for non-vigorous term and near-term infants? If not, what more information is needed? And will this change your practice? And I was able to pull our institutional guideline at UCI. And if you see there at the bottom, I can highlight it, that we now, as of July of 23, include this: consider cord milking in infants above, in our institution, we do consider it above 29 weeks corrected. So, and then we outline essentially what the MINVI trial, how they went about cord milking. So it is standard for our institution, you know, at every delivery, when NICU is present with MFM, we'll discuss the cord management plan. And so this study has certainly informed my ability to do that. So I welcome the last slide's just thanking for everyone, Dr. Katheria, Dr. Seidler, Dr. King, Dr. Wolf, Dr. Jane, and then my program director, Dr. Benny, who also reviewed my slides. Would love to welcome, you know, open it up to others here about how this has changed their practice, and if not, why not?
Dr. Benny asked a question in the chat. Because Dr. Katheria, when you were talking about the 2-year outcomes, I think a lot of your phrasing was around the safety of milking, right? I think that was the concern people had going in, was in preterm infants, there's this harm signal. So is it safe to do? But I think it's also reasonable after the original trial, particularly with some of those secondary outcomes, like the receipt of therapeutic hypothermia, to wonder not only is it safe, but is there a benefit? And so the question was, you know, seeing those short-term benefits, thinking about not just safety, but, you know, why didn't we see a benefit from that? Obviously, there was a small number of babies, you know, among the total, as you talked about. You know, we have so many babies and so few of them actually end up needing an intervention that becomes challenging to detect those. And then I think also, you know, Colin mentioned specifically among those cooled, even you saw, you know, roughly half of them were being cooled with mild hypothermia based on the breakdown of mild, moderate, severe, which also makes you think potentially even less likely to see a benefit in that population. We don't know, but any other thoughts about sort of that? Like, you know, not just is it safe, but, you know, should there be a benefit signal here at 2 years?
Yeah, I know. I think those are all good points. Sorry, the survey just popped up on my screen.
Sorry.
No. So a couple things. One is, yes, I think whenever we do any trial, forget about cord management, anything in neonatology, we always are looking for that holy grail, that 2-year benefit. And time, we keep getting really disappointed to see those things translate in practice. It just becomes such a huge lift to find something that has that sort of long-term effect. I will say, if you go back into the history of why we are even doing delayed cord clamping, not just in our country, but across the globe. I mean, for us in the US, it's always been about that ACOG recommendation. So 2012 was preterm babies. And then it wasn't until 2015, they started looking at term babies. The only reason term babies even became recommended, which sort of seems silly, like term babies, of course we do delayed cord clamping. It was because of Ola Andersson's work in Sweden. And in his studies, he did a 1-year study, a 2-year study looking at delayed cord clamping versus immediate cord clamping, showed no benefit at 1, no benefit at 2. And it wasn't until his JAMA PEDS paper at 4 years, he saw a signal, mostly in boys, but also some in girls, that showed this benefit of developmental scales at 4 years of age. So I think there is something where, if you get, you know, clearly, well, I shouldn't say clearly, in the MINVI trial, babies had higher hemoglobins compared to early cord clamping. And I think it seems sort of intuitive. If you milk a cord compared to clamp early, you're giving them more blood, but you're also giving them more stem cells. And I think Colin had a nice slide about the whole stem cell bit with cord milking, which actually is in some ways better than delayed cord clamping. it's hard to see effects like in some of these kids, I think, early on. And I wish we would have been able to do a longer study, even out to 4 to 5, to see if there are effects in these kids with more detailed assessments and maybe look for a benefit signal. But the other piece is, 10, university, community hospitals with good resources, it's harder to see that sort of signal. By next April, we're on a path to have a virtual replica of MINVI. It's called Cord Milk, and it's in 3,300 non-vigorous babies born in India that have 10-fold higher incidence of HIE. And I think, that should really give us more information of whether cord milking has a benefit on HIE as well as long-term outcomes. I think looking at 24 babies versus 12, it's not a huge number to really say a whole lot about what's the HIE effect. I mean, I don't think anybody right now in the neonatal community is like, oh yeah, I'm using milking as my HIE therapy. But I think in a higher incidence sort of population, I think that's where we'll really be able to know if milking has a benefit. And I will tell you, even as somebody conducting these trials, I love to see at least one other trial that shows that same signal. I mean, in fact, I still wish somebody could do the preterm version of our cord milking trial that shows that same similar signal, so we can validate that, even though that sounds, that was a horrible outcome for these kids. We're not seeing any of that, so it makes it very nuanced. And I think anybody, like even when Lene is looking at data, seeing 2 trials coming in together showing that same signal, then I would say we have definitive data that we should be doing this on every non-vigorous baby. Because you're sort of seeing 2 large RCTs. And I think that should be our gold standard for anybody who's looking at an intervention, is to have that sort of dogma. It shouldn't just be one trial, even if it's multi-center, sort of influencing what everybody's doing. I mean, that's just my take.
Yeah. So, Dr. Katheria, there's some really good things to see in this trial. Your use of the prenatal consent, waiver of consent rather, in those patients and stuff, the crossover design and stuff. So how are IRBs responding? You handled 10 hospitals about this consent to be waived and stuff. Is this the future we're gonna see in neonatology? IRBs getting more open to these ideas?
No, not in our country. I think if you live in Australia or Europe, one of those countries, you'll see a lot more of that. We have a huge battle to sort of make this work. And we're trying to work with some of the other, if there are other neos that are interested, one individual, Matt Razavi, has been doing a lot of great work in Houston, trying to push the needle with some trials. But any of you all that want to do this, we have to sort of engage together, because IRBs are not interested in the United States of doing waiver trials. A lot of it has to deal with support, and we don't have to go into all that. But I think that there's a fear that, if a baby has a bad outcome, and you didn't have consent going into it, well, those shouldn't be babies included in these types of studies. But those are the exact babies that we're looking at. And I won't say too much because we haven't published the paper, but I will tell you that waiver trials actually have the ability to uncover a risk that we're not seeing in current trials. I just saw, I follow Brian a lot on X or Twitter, and they're just talking about the PLUS trial. You look at studies where we have to do consent before the intervention, and we always have these interventions that enroll lots of well kids, and we get a null value. Whereas other trials that were able to get waivered consent, like Ye studies on budesonide, didn't have to do that. And I think this is where we have to think about, if we want to know if milking is bad, we'd still be doing cord milking in 23, 24 weekers and pre-MOD 2 if we only use the consented families. So same thing with sustained inflations. I think we need to think about this when we're designing studies. And hopefully some of you will be interested in that topic, Viral, to push this, because otherwise we're going to be stuck with a bunch of negative studies. So I'll stop and let Lene has a point.
Yeah, I just wanted to add to that with the waivers of consent. In Australia, we've just had a very large trial on a similar population that's randomized to different oxygen concentrations, where hospitals were already doing a mix of both. So it would have been quite obvious that, well, the baby's going to get one or the other. We don't know what's better. And there was a major media outcry, and they got into a lot of trouble, even though they had got that waiver of consent approved. So I think generally people are very sensitive to that idea of children being randomized in trials without the parents' knowledge or consent, which is a big problem because how else are you going to do these studies well?
Yeah, I think some really important things to work for future trialists. As Dr. Katheria pointed out, they're probably important to get those babies which do not sign consent. A lot of risk can be uncovered. I'm just going to share the poll results which we have. So pretty evenly divided, 50% of our audience members practice cord milking from the studies and stuff. And almost all of them agree that we still need long-term data and stuff going forward. So a huge amount of work still made to be done in this topic, and we're glad Dr. Katheria and Dr. Seidler are pushing the needle forward in this one. So before we wrap up, Dr. Seidler, do you have any comments for us? You have been looking at all these babies, combining trials. For all the future trialists, where should they focus their attention on if they want to work in this arena?
I think Anup's already doing a lot of actually amazing trials in this area, so I wouldn't be able to do my analysis without his trials, really. But I think one thing that was mentioned briefly in the beginning was the whole debate around resuscitation with the cord intact. And there are lots of kind of infant studies coming out in preterm infants on that. But I think really these are the three. Like we've looked at two options today. There is a third option. It's a maybe more complicated option. It's a more expensive option. It's still something we need to also think about and study in this whole context. And having those three different options in comparison and combining the data on these hopefully will give us a final answer on how to best help these babies.
Right. Dr. Katheria, do you have any other comments for our trialist here in the audience?
Only that, I think at the end of the day, starting with studies that you really have, a passion to look for. I think don't focus on so much what, other people are doing or being interested. I never knew I was going to get into cord management per se, but, it's something that you notice when you're taking care of patients or in the NICU. I think there's lots of opportunities to do single-centered studies and then sort of broaden that out. But I think it's really important to stick with, because you'll run into blockades with IRBs or other things that if you're not passionate enough about it, it really becomes an uphill battle. So just encourage you all to, find those questions that you're looking to answer and start doing them at your own hospital. Go from there.
Yeah, I think it's great, as Dr. Katheria has proven, even though the initial signals were not clear, he pursued and kept looking for the answer and finally moved things forward. So very, very grateful for it. And a lot of us, a lot to learn for us trainees moving forward, how to do design trial. And as you said, COVID shut down the study almost, and being ingenious about how to track the outcomes, even to move and give us some results going forward. So very, very grateful for Dr. Katheria and Dr. Seidler, both of you, to come share your expertise with us. We will have a next Journal Club session on Thursday, December 12th, again, 3 p.m. Eastern, on the Diamond Trial, another very interesting topic on nutrition, another international mentors presenting. So I look forward to see all of you again there. Thank you so much for coming. I'll see you next time. Thank you so much, Dr. Katheria.
Thanks so much, guys.
Thank you, everyone.
Bye.
Thank you.